I'm delighted to talk today about neuroblastoma radiotherapy dose and target and neuroblastoma palliation. I'm Anne Laprie. I'm a radiation oncologist in France, in Toulouse. And I have no conflicts of interest. I thank the organizer for inviting me to talk about this very interesting subject. Neuroblastoma radiotherapy is mainly suprarenal. It can also be thoracic or pelvic. The most frequent indication is neuroblastoma when we do a radiotherapy outside of brain in children. The indication is mainly tumor bed in high-risk localized and metastatic neuroblastoma after chemo, surgery, high-dose chemo, and it is followed by maintenance therapy usually. And more rarely are we irradiating them by tumor paper or palliation. It's a radiation that we deliver in young children, median age being 2 years, and it's a radiosensitive tumor. We use a standard dose that is around 21 gray, but we still have questions about boost residual tumor. So radiotherapy volumes are based on post-chemo pre-operative volumes. Is it better to use CT or MRI? Well, anyway, diagnostic CT is the most easily available with a short examination time. We talk here about small children. We will nevertheless really appreciate the diagnostic MRI in pelvic tumors, metastatic marrow disease, chest wall invasion, spinal canal involvement, but it's a long examination in small kids and anesthesia is often needed. And for pre-operative surgical planning, we will often have a CT because surgeons prefer CT. They see better the solid portions of the mass, the extent of calcification, the vasculature, the encasing of major vessels too. Sometimes we have both. Anyway, we will use with our planning CT, we'll use this pre-operative imaging, either CT or MRI, and we will be very cautious because CT or MRI are not performed in treatment position. We have this very flat radiotherapy table and this very curved diagnostic table, and moreover, organs will have moved. So we will give a priority to the discussion with the radiologist, to the discussion with the surgeon, and the anatomic pathology report, and the clips left by the surgeons are very useful. What will be our volumes? Well, we will delineate a virtual JTV because this for example, here we see the tumor, but of course, after surgery, the organs have moved, and we will take the regions that was involved, and then we will add a 0.5 centimeter margin to the tumor, and then delineate the vertebra and make sure that we have whole vertebra, or in exceptional cases, or if we are very close to kidney, depending on the anatomy, exclude the secondary growth plate to absolutely include the primary growth plates. And of course, we will delineate all the organs at risk in the region irradiated. What dose we will use? Well, we'll do so around the 21 gray. Here is a panel of many papers that were published recently, and we really stick to a dose around 20 gray. Is it a 24? Is it a 21? Is it an 18? Anyway, with this approach, even in metastatic children, we have a very good local control. Which technique we will use? Well, we are all heading for VMAT, IMRT, of course. It gives a better conformality. It's the best method in midline tumors because the best method to protect both kidneys. But it has a cost of a higher mean dose to the liver, stomach, and spleen. And we have to compare sometimes with standard RT if it's a lateralized tumor. And never forget the basic rules of including the vertebra and the bones in a very symmetric way, less possible gradients, and be very much cautious about the doses that are delivered outside and inside the field. For example, here, two comparative dosimetry for the same child with neuroblastoma and post, which was quite median, and then suprarenal on the left side. And we can see that we compare two opposed obliques with IMRT, and that we see on the dose volume histogram that tumor is well covered anyway, that we have exactly what we expect on the liver, comparing IMRT and standard dose, that we deliver more dose, but then very small dose with IMRT. The kidneys are approximately experiencing the same DVH difference that we know between IMRT and standard radiotherapy. So then it's up to the radiation oncologist to choose regarding his priorities. And also regarding if he has good IGRT to deliver properly IMRT. Anyway, I really like this paper who proposed a decision template. And here we are here in these regions where there are good bony landmark surrogates with vertebrae. And I stick to this recommendation of the daily KV imaging and weekly 3D imaging to lower the delivered dose and still have a very good repositioning, and particularly very sharp on the dose gradients on the vertebra between the irradiated vertebra and the protected vertebra. Do we need to deliver a boost for neuroblastoma? It's an important question in our community. In the European first neuroblastoma high dose trial, we saw that children with macroscopic residual tumor experienced a 38% event-free survival, whereas the ones with complete resection experienced a 49% event-free survival, and all received the same dose of 21 gray. In the German study, only children with MIBG positive residual tumor would undergo radiotherapy. There would be a high rate of relapse without radiotherapy, and 43% relapse in patients with residual tumor versus 24 if they had no residual tumor. A retrospective study showed that there was no local failure if a dose was higher than 30 gray, but it was in a small number of patients. And finally, the last results published in JCO last year showed an historical comparison of the results of the COG trial that had planned a boost in case of residual tumor and showed no benefit, but still it was a historical comparison. So we still have this pending question: will dose escalation beyond 21 gray translate into better outcomes for patients with residual disease? So that's a question that we are asking in the high-risk neuroblastoma trial now, with a randomized question about induction chemo, about high-dose chemo, but also a randomized question about radiotherapy. All patients will undergo a 21.6 gray by 1.8 gray by fraction if they have no macroscopic residual disease. But if they have, we will randomize, because we finally don't know if we have to boost. And some will have 21, some will have 36. They will be stratified according to age, weekend status, induction care chemotherapy arm, high-dose chemo arm, and the country of treatment. And our aim is to go from our 28% event-free survival to a 53% event-free survival in this residual tumor children. Of course, we'll have online quality control. It's super important to really be able to answer the questions once we have done the trial. And so we are organized with a quartet system to have a centralized European prospective online quality control. Do we need to irradiate MIBG plus metastasis when we irradiate the primary in case of stage 4 neuroblastoma? Well, there was a recent German study who showed that there was a good control of irradiated metastatic sites compared to non-irradiated metastatic sites, but no benefit on survival, so no real argument to do that for all patients. And we don't do it in our SIOP. For example, I had a case 14 years ago with a baby who had still a very strong MIBG fixation on an orbital metastasis and a complete tumor bed resection. And while doing general anesthesia, validated on the post-forum at that time, we radiate both sides, and the child is perfectly cured and has no net effect 14 years later. But still, there is no, in the European trial, no irradiation of metastatic sites. And then what are the main potential late effects in this tumor? There are several, and we are very cautious with the organs at risk doses, particularly with the spinal cord doses, because we use busulfan melphalan, so we will be less than 30 gray even if a boost. Otherwise, it's quite classical irradiation. And we know that there is lead toxicity in high-risk neuroblastoma that is really linked with the dose, and that when you go higher than 31 gray, there are more musculoskeletal abnormalities, particularly the number of vertebrae radiated, less or more than 7. This is an extreme case because we are very used to seeing no lead effect in our children irradiated for neuroblastoma, but for example, in a child irradiated at age 4 on 10 vertebrae, we really have an impact on her growth. So we have really to I would recommend following the guidelines from all that we published in Lancet Oncology recently, and we here have a deciding arm to choose and really have the less gradient possible in the vertebrae. And we know that metabolic syndrome appears in these children, so we really have to know that and take that into account. And wonder if there is an interest in motion management. If you're really worried about some organs, you should use 4DCT because we can't really know how everything is moving in the abdomen of children. And then to end up, I would, there was a question of palliation. Of course, it works very well on bone metastasis in either single dose or fractionated. Be careful of teenagers. Consider them like adults with an adult carcinoma. They are more resistant. And if you have medullary repercussion, go for a good dose, but take into account that it has to be equivalent of 30 gray by 2 grays if there was BML. Otherwise, go for 30 gray by 3 gray. Meningeal extension can sometimes be treated with remission with crinospinal, hypofractionated crinospinal. Pieper and Hutchinson can also be irradiated in very rare cases with good results. And to wrap up, there is 6 take-home messages for radiotherapy of neuroblastomas, with the second most frequent indication for pediatric after brain. You can use standard or IMRT. Be very, very careful with bone irradiation. Try to stick to less to 7 vertebrae. Treat within our prospective trials with this dose escalation randomized question for radiotherapy and online quality control. And of course, the very nice question is what are proton therapy? And Beat Timmerman is going to talk about that now. Thank you very much.